Welcome to All in All. This deep dive is really geared towards you, our colleagues, the dialysis RNs and techs, working incredibly hard on the floor every single day. Whether you're aiming for that RN role or just want to sharpen your understanding, we know your expertise is focused on kidney replacement therapy.
Absolutely, but there's so much value in looking upstream.
That's exactly it. Understanding what happens long before a patient needs dialysis.
Right.
So today we're doing a deep dive into the actual disease drivers behind chronic kidney disease, CKD.
Yeah, it's not just about managing kidney failure once it's happened. It's really about getting a handle on the fundamentals, the processes that lead to CKD in the first place.
And how knowing that helps us provide better care across the whole journey.
Precisely. Our goal here is to give you a really solid understanding of CKD's root causes, how we evaluate it, and the latest management strategies from guidelines and research.
Because that knowledge really underpins everything, even the excellent care you're already giving during dialysis.
It absolutely enhances it.
Okay, let's jump in. CKD. It's obviously more than just kidneys aren't working. What's the actual sort of clinical definition we're using?
So the formal definition really focuses on two things: evidence of kidney damage or decreased kidney function. And the key is that this has to be present for 3 months or more.
3 months. Okay, so that chronicity is built right in.
Exactly. And that decreased function has a specific threshold. A glomerular filtration rate, the GFR, that's less than 60 millimilli, 1.73 millimills.
Got it. And classifying CKD, I know it's not just that one GFR number anymore.
No, definitely not. The approach now is much more comprehensive. We classify CKD based on 3 components: the underlying cause,
the
GFR category, and the albuminuria category, so CGA.
CGA. Cause, GFR, albuminuria. Makes sense. It emphasizes that GFR is only part of the story.
That's right.
So let's look at those GFR categories first. G1 down to G5. What are those levels?
Yep. G1 is a GFR of 90 or higher, so basically normal or even high function.
Okay.
G2 is 60 to 89, mild decrease. Then G3 is split. G3A is 45 to 59. And G3B is 30 to 44.
Right.
G4 is 15 to 29, a severe decrease. And G5 is less than 15, which is kidney failure.
In that threshold for diagnosing CKD, the GFR under 60, that's quite a drop from what a healthy young adult might have, isn't it?
It is, but it's also worth noting, especially in younger people, that a significant fall in GFR, even if it stays above 60, is often a red flag.
Okay.
Particularly if it comes with other signs of kidney damage, like albuminuria. That helps catch things earlier.
So you mentioned albuminuria. That's the A in CGA. It's about protein in the urine.
Specifically albumin, yes. It's classified using the albumin-creatinine ratio, or ACR.
ACR.
A1 is less than 30 milligrams per gram. That's normal or just mildly increased. A2 is 30 to 300 milligrams, moderately increased.
Okay.
And A3 is over 300 milligrams, which is severely increased albuminuria. And albuminuria is, well, it's a really sensitive marker, often one of the earliest signs of damage to the glomeruli, the kidneys filters.
So combining the GFR stage and the ACR stage, that gives us that grid we sometimes see.
Exactly. The GFR albuminuria grid, it plots GFR stage against albuminuria stage, usually with colors like green for low risk, moving through yellow, orange to red for the highest risk.
Right, I've seen that heat map.
Yeah, it's a fantastic visual tool. It helps predict the risk of CKD getting worse or other bad outcomes like cardiovascular events. And the color actually guides how often we should be monitoring that patient's GFR and ACR.
Makes sense. Red means higher risk, so more frequent checks.
Precisely.
That grid is really practical. Okay, so we know what CKD is, how we stage it. Now let's think about the why. What are the main things actually causing this kidney damage? The drivers.
Well, globally, the two absolute giants are diabetes and hypertension. They account for the vast majority of people who end up needing dialysis.
Diabetes is number one.
Diabetes is the single leading cause of end-stage kidney disease, yeah. Glomerulonephritis inflammation of those filters is another big one.
And sometimes it's genetic, right? Like polycystic kidney disease.
Absolutely. Autosomal dominant polycystic kidney disease, ADPKD, is a classic example of a specific genetic disorder directly causing CKD.
What about other systemic diseases, things affecting the whole body?
Yes, definitely. Things like connective tissue diseases, maybe systemic sclerosis, or certain blood disorders involving abnormal proteins. You might hear the term MGRS, monoclonal gammopathy of renal significance. Those can hit the kidneys hard.
And medications. That's huge for our patients. Can drugs or other substances be drivers?
Oh, critically important. We all know about nephrotoxic medications, but we also really need to ask about herbal remedies and
Yeah,
supplements.
that's a good point.
They can have complex, potent ingredients, sometimes not well studied, and can cause direct damage or interact badly. Aristolochic acid nephropathy from certain herbs is a really nasty example.
Wow. Really drive home the need for a thorough medication history, including everything.
Everything. And sometimes just chronic illness itself can affect the markers we use, like creatinine or cystatin C, separate from the actual GFR. These are called non-GFR determinants.
Okay, so that covers the what's and the why. Now, evaluation. How do we actually spot CKD, ideally before people even feel sick?
Early detection it's everything. Because CKD is often silent early on, we need to actively screen people who have risk factors.
Like diabetes, high blood pressure, family history.
Exactly. Finding it early means we can intervene sooner, maybe slow things down, give people a chance to make lifestyle changes. We know people want to do that if they know early enough.
Right. So, say you suspect CKD. How do you pin down the specific cause for that patient?
It's like detective work, really. You start with a deep dive into their history, medical, family, social, environmental factors, and that super detailed medication and supplement list again.
Okay.
Then a physical exam, lab tests targeted to potential causes, maybe imaging like a kidney ultrasound.
And sometimes more specialized stuff.
Yeah, sometimes you need genetic testing or even a kidney biopsy if the cause isn't obvious or you suspect something specific that needs tissue confirmation.
Let's get into the GFR assessment a bit more. The standard first step is estimated GFR using serum creatinine, right? The eGFR-CR.
Yes, using validated equations like the CKD-EPI creatinine equation, it plugs in the patient's serum creatinine, age, and sex to give that estimate.
But it's an estimate. What things can make it less accurate?
Several things. If kidney function is changing fast, like an AKI, the creatinine level lags behind reality. That's a non-steady state.
Correct.
And factors other than GFR affect creatinine itself. Muscle mass is a big one. Diet, certain meds, conditions with high cell turnover, those non-GFR determinants again. And of course, lab errors can happen.
So that's where cystatin C comes in sometimes. We see that ordered.
Exactly. Cystatin C is another marker filtered by the kidneys. Using equations that include both creatinine and cystatin C, the eGFR-CRC equations often gives a more accurate GFR estimate.
When would you specifically use that combined equation?
It's particularly useful when you suspect the creatinine-based estimate might be off. Think extremes of body weight, muscle wasting, maybe amputees, or certain cancers or inflammatory conditions.
And sometimes you need even more precision. Measured GFR.
Rarely, yes. If a really precise GFR number is critical for a major decision, like certain drug dosing or transplant evaluation, a measured GFR using an injected tracer might be done. But that's complex and not routine.
Gotcha. And what about the race coefficient that used to be in the GFR equation?
That was removed in the 2021 CKD-EPI equation. The consensus was strong that using race as a variable was problematic, lacked biological basis, and could worsen health disparities. So it's gone.
Good to know. Any special points for GFR in kids?
Oh, definitely. For infants especially, labs should use enzymatic creatinine assays to avoid interference. And for kids over 2, a GFR below 90 is flagged as low, prompting follow-up, unlike the adult 60 threshold.
Lower threshold for concern in kids.
Right, and puberty is a time to watch closely, as GFR can change with muscle mass development.
Okay, that's GFR. Now, albuminuria assessment. Why focus on urine albumin specifically, not just total protein?
Albumin is smaller, and its presence is a much more specific and sensitive sign of damage to the glomerular barrier, the filter. Measuring total protein is less precise and can pick up other proteins that aren't related to that specific type of damage.
Makes sense. And for collecting the sample for the ACR, does it matter if it's first morning or random?
An untimed spot sample is fine for screening initially. A first morning void is often preferred because it's usually more concentrated and better reflects 24-hour excretion, plus it helps rule out orthostatic proteinuria.
What's that?
That's when protein only shows up in the urine when someone's been upright, not when they're lying down.
Oh, okay.
But really, a random sample is acceptable if that's what's practical. The key thing is calculating the albumin to creatinine ratio, the ACR. That corrects for how dilute or concentrated the urine is.
Right, gives you a standardized value.
Exactly. And across all these tests, creatinine, cystatin C, albumin lab accuracy, and consistency over time are just vital for good monitoring.
Speaking of monitoring, what kind of change in GFR ACR should make us worry about progression?
Yeah, good question. You're looking for sustained changes beyond just normal day-to-day variation. Typically, a confirmed drop in GFR of more than 30% from their baseline,
Okay.
or a doubling of the ACR category, say from A1 to A2 or A2 to A3. Those kinds of shifts warrant a closer look and evaluation for why things are progressing.
Got it. Okay. This is great context. We know what CKD is, the causes, how we evaluate it. Now, the really crucial part for practice, management. How do we try to slow things down, manage complications, keep people off dialysis longer?
The strategy has to be comprehensive. You're really trying to hit 3 targets. 1, modify the disease course itself. 2, treat the complications that pop up like anemia or bone disease. And 3, manage the associated risks, especially cardiovascular disease, which is a huge threat in CKD.
And lifestyle is always foundational, I see.
Always. Encouraging physical activity tailored to what they can safely do, aiming for a healthy weight, and absolutely stopping smoking are non-negotiable. And using the whole team, referring to renal dietitians, pharmacists, maybe mental health support when needed, it's a holistic approach.
Let's talk diet. That comes up constantly. Protein recommendations.
For adults in stages G3 to G5, the general guidance is around 0.8 grams of protein per kilogram of body weight per day.
0.8 kilograms.
Yeah. And importantly, avoiding high protein intake, like over 1.3 kg day, if they're at risk of progression. Some very motivated patients might even consider supervised, very low protein diets with special supplements, but that needs close monitoring.
But is that protein restriction the same for children with CKD?
Absolutely not, T. That's a critical difference. You do not restrict protein in growing children with CKD. It can impair their growth.
Okay, vital point.
Their protein intake should actually be at the upper end of normal for healthy kids to support growth. And alongside protein, managing sodium intake is usually important, often linked closely with blood pressure control.
Right, blood pressure.
Yeah.
That's got to be a cornerstone.
Arguably one of the most critical things we can do to slow progression. Following guideline targets is key. And the renin-angiotensin system inhibitors, ACE inhibitors or ARBs are usually first line, especially if there's albuminuria.
ACEs and ARBs.
Yes. And when you start them or increase the dose, you absolutely need to check blood pressure, creatinine, and potassium within about 2 to 4 weeks.
Check labs after starting.
Got it. And never use an ACE inhibitor and an ARB together. That dual RAS blockade is a no-go due to safety risks. For kids, the BP target is even tighter, aiming for a mean arterial pressure at or below the 50th percentile for their age and height.
Okay. Now, medications. There have been some real game changers recently, haven't there? SGLT2 inhibitors.
Huge impact. Strongly recommended now, not just for type 2 diabetes with CKD, but trials show benefit in non-diabetic CKD too.
Even without diabetes.
Yep. Generally started if eGFR is 20 or above, and often continued even if GFR drops below 20, unless there are side effects or the patient starts KRT.
KRT meaning kidney replacement therapy.
Right. A key practical point for us on the floor. SGLT2 inhibitors need to be held during times of prolonged fasting, surgery, or acute critical illness due to the risk of euglycemic ketoacidosis.
Okay, hold for surgery or critical illness. Good to remember.
Trials like Credence, DAPA-CKD, MPA-Kidney showed major kidney and cardiovascular benefits.
What about MRAs? Mineralocorticoid receptor antagonists.
Another important class. The non-steroidal ones, like Finerone, have shown kidney and cardiovascular benefits, particularly in diabetic kidney disease.
Finerone.
Yeah. The older steroidal ones, like spironolactone, are still used for heart failure or resistant hypertension, but they carry a higher risk of hyperkalemia, high potassium, and a temporary GFR dip, especially at lower GFRs.
So potassium monitoring is key with MRAs.
Absolutely crucial with both types, non-steroidal and steroidal. There are specific monitoring protocols.
Okay, and GLP-1 receptor agonists. We see those a lot for diabetes. Any specific kidney role?
Their main benefits are glucose lowering and cardiovascular risk reduction. But agents like liraglutide, semaglutide, dulaglutide are often good choices in CKD because they typically don't need dose adjustments based on GFR.
Simpler dosing. That's helpful.
Definitely.
Okay, beyond slowing progression, CKD brings complications. Metabolic acidosis is one.
Yes, as kidneys fail, they can't get rid of acid properly. That acidosis is linked to things like muscle breakdown. We treat it with sodium bicarbonate.
Bicarb.
Right. But interestingly, recent big trials haven't definitively proven that treating acidosis slows CKD progression itself. If you do treat, you need to monitor carefully. Don't overshoot the bicarb level. Watch BP, potassium, fluid status.
Hyperkalemia, high potassium. We deal with that constantly in dialysis, but It's an issue before dialysis, too.
Absolutely, and it's often multifactorial, while severe dietary restriction isn't usually the long-term answer and can cause malnutrition. You really need to look at medications that raise potassium, acidosis, uncontrolled blood sugar, constipation, and the level of kidney function itself. Those are often bigger drivers than just the potassium in their diet.
Good perspective. What about uric acid and gout?
Uric acid levels often rise in CKD. We
Yeah.
typically consider starting uric acid lowering therapy, like allopurinol, after someone has their first gout attack, especially if they have moderate to severe CKD or really high uric acid levels.
After the first attack?
Yeah, and you have to warn them about potential gout flares when starting the medication, but there isn't strong evidence to treat high uric acid if they haven't had gout, just to try and slow CKD progression.
Okay. Cardiovascular disease is tied so closely to CKD.
Incredibly tightly. Standard practice is to estimate their 10-year cardiovascular risk, and statin therapy is crucial to lower LDL cholesterol and reduce that risk.
And AFib, atrial fibrillation, seems really common, too.
Very common, and the risk goes up as CKD stage worsens and with more albuminuria. The basic diagnosis and management principles are similar to people without CKD.
What about anticoagulation for stroke prevention in AFib? NOACs versus warfarin.
For non-valvular AFib, the newer agents, the NOACs or DOACs, are generally preferred over warfarin. Meta-analyses suggest they reduce stroke risk, especially hemorrhagic stroke, compared to warfarin.
Okay.
But the data is a bit more limited in advanced CKD stages G4 and G5. And a really practical point for us, especially thinking about procedures like fistula placement, is knowing when to hold these drugs based on bleeding risk, the specific drug, and the patient's GFR. There are guidelines for that.
Right, timing the hold is key. What about stable ischemic heart disease in CKD? Medical therapy versus invasive procedures.
Good question. Trials looking specifically at CKD patients with stable angina suggest that for many, starting with aggressive medical management gives similar long-term outcomes compared to rushing into stenting or bypass surgery.
So medical therapy first is often appropriate.
Often, yes. Invasive procedures can be trickier in CKD due to things like heavy artery calcification and small vessel disease. Management often focuses on controlling angina symptoms.
This leads us right into medication management, overall drug stewardship. Our patients are often on so many meds.
And this is where dialysis nurses and techs are so vital. People with CKD are just much more susceptible to medication side effects, especially kidney toxicity. So rule number one is always carefully weigh the benefits versus the harms of any drug in someone with CKD.
What kind of monitoring is crucial?
Beyond just checking GFR and electrolytes, you need to think about therapeutic drug monitoring for drugs with narrow safety windows like certain antibiotics or heart rhythm meds, and always be vigilant for any adverse effects, especially kidney-related ones or signs of drug accumulation.
How do we get the dosing right when GFR can vary?
For most drugs, the standard eGFR equations are okay for dose adjustments, but if it's a drug with a narrow therapeutic range, high risk of toxicity, or if you think the eGFR-CR might be unreliable for that patient.
Like the muscle wasting examples.
Exactly. Then, using the eGFR-CRC's equation, or in rare cases even a measured GFR, might be needed for more precise dosing. Sometimes for patients at extremes of weight, using the non-indexed GFR is helpful for certain drug calculations. And always adjust dosing if GFR is changing rapidly, like during AKI or if other factors are at play.
And medication reconciliation.
Huge. Performing thorough med reviews regularly, and especially at transitions of care hospital discharge, starting dialysis is critical. Checking adherence, making sure every drug still has a valid reason, looking for interactions.
And making sure there's a plan to restart meds that were held during an illness.
Yes. That gets missed surprisingly often. Having a clear plan for restarting essential medications is key.
Okay, shifting gears slightly. For patients whose CKD is progressing despite everything, planning for kidney failure and supportive care becomes the focus.
Absolutely. We can actually predict the risk of needing KRT using tools like the kidney failure risk equation, the KFRE. Yeah. It estimates the chance of needing dialysis or transplant within, say, 2 or 5 years for patients in G3 to G5. A high risk, maybe over 40% at 2 years, can trigger timely discussions about modality options, access planning, or transplant referral.
And getting patients to a nephrologist earlier seems beneficial.
The data strongly suggests yes. Early referral is linked to better survival, fewer hospitalizations, more timely KRP access creation, and better control of things like BP and anemia before dialysis starts. It might even slow progression, though that's harder to prove definitively.
What about the symptoms of uremia? We see that burden daily.
It's immense and often under-recognized or undertreated. Fatigue is probably the most common, but things like itching, nausea, sexual dysfunction, they hugely impact quality of life.
Which is what matters most to patients often.
Exactly. So using standardized symptom assessment tools regularly in advancing CKD is really important for patient-centered care and making decisions together.
And discussing the actual KRT options.
Essential to provide clear, balanced information on hemodialysis, peritoneal dialysis, and transplant. And crucially, also presenting comprehensive conservative care focusing on quality of life and symptom management without dialysis as a valid, supported choice.
Conservative care as a positive choice, not just giving up.
Precise.
And supportive care isn't just for the very end, right?
No, not at all. Supportive care is about improving health-related quality of life at any stage of CKD, even alongside dialysis or transplant. A big part of this is advanced care planning, or ACP.
ACP.
It's that ongoing conversation between patients, families, and the care team to clarify values and preferences for future care, especially as things might change functionally or cognitively.
There was an interesting point in the sources about when to start dialysis. Earlier isn't always better.
Right. A major study, the IDEAL trial, found that starting dialysis earlier, when GFR was still 10-14, didn't improve survival over 5 years compared to waiting until GFR was below 10, typically closer to 7.
So it's not just about the GFR number.
No, it's a clinical decision based on symptoms, fluid status, nutrition, and patient preference, not just hitting a specific GFR target.
It's clear this field is complex and still evolving. Did the sources mention areas where more research is needed?
They did. While we know a lot, there are still gaps. We need more research in specific groups, like people with ADPKD, type 1 diabetes, kids, older adults, pregnant individuals. Also, questions remain about combining sodium restriction effectively with medications, the best use of genetic testing, developing even better risk scores, and really fine-tuning drug dosing for individual needs.
This has been incredibly thorough. We've really traced CKD from its diverse beginnings and classification through the detailed evaluation and into the multifaceted management strategies, all the things happening before dialysis.
And seeing that whole picture is so valuable for you. Working on the dialysis floor, it adds context to the meds patients are on, the labs that were monitored before they started KRT, the lifestyle advice they received.
Yeah, it reinforces our role in education, monitoring, recognizing changes, being part of that whole care continuum.
Exactly. You're not just managing KRT. You're a key part of comprehensive kidney care.
So here's a final thought to consider. Given this complexity, the drivers, the evolving management, how can we in our daily interactions best integrate these insights to support truly patient-centered, comprehensive care, even before kidney replacement therapy becomes necessary? Something to really think about. Thanks for listening to All in All.